For those who've not attended a Westminster Health Lecture event before or are watching on the recording for the first time, this series is designed to give BMA members the opportunity to listen to the key priorities of the main political parties, as well as ask any specific questions. And I would remind you that we are going to be recording and publishing this recording tonight, so when you ask questions later, a couple of things. Please, first of all, speak into the microphone when it arrives rather than generally shout, because we can hear you, but the people at home, as it were, won't be able to. And secondly, if you could introduce yourselves as well when you speak, that would be great. So over the past few months, many of us have heard a range of statements and commitments from politicians, and this series provides a chance to scrutinise those statements more closely and provide members with a forum to find out more. At our first event, we heard from Dr. Gillian Creasy, the Green Party spokesperson for health and social care. She spoke to us about the Green Party's opposition to private sector involvement in the NHS and their desire to shift more care into community settings and invest more in primary care and in community health. We then heard from Paul Burstow MP of the Liberal Democrats, who told us that £8 billion of the funding gap facing the health service could be met by 2020 if politicians would commit to an extra £1 billion a year. Mr. Burstow also told us that there should be an independently led review to look at the issues of health and social care funding across the entire piece. Most recently, we've heard from Dr. Clive Peedle of the National Health Action Party, who told us about the NHAP's concern that the Health and Social Care Act has opened the door to privatisation in the National Health Service. Tonight we'll hear from UKIP, or the United Kingdom Independence Party. We may learn about more about their plans to ensure that visitors and migrants coming to the UK have NHS-approved health insurance, and their plans to ensure that GP surgeries are open for at least one evening a week. It'll be another opportunity for members to scrutinise health policies directly with the individuals who may be making decisions after the next general election. As we look back to the last one, over the last 5 years of this Parliament, the NHS has faced many challenges, including the huge top-down reorganisation that resulted from the Health and Social Care Act. There have been funding pressures that resulted from measures badged as efficiency savings, and we've all felt those, dictated by the Nicholson Challenge. These challenges are at a time when service demands are increasing as a result of an increasing ageing of the population and indeed an increase in the population itself. Reductions in funding for social care have also caused reliance on hospital services for those who don't receive adequate services to meet their social care needs. This exit block in secondary care that we've talked about quite a lot over this last winter has caused problems at the front door and led to problems with emergency department performance management figures, or the barometer of the entire service. We've also seen challenges in general practice as increasing demands caused by the demographic changes I've talked about, more complex healthcare needs, and indeed care moving out of hospitals has led to unsustainable pressures on the service. These pressures are compounded by workforce and resourcing problems, all of which are having a direct impact on patient care. An incoming government will have the opportunity to tackle the current issues faced by our NHS, and the BMA is calling upon that government to ensure the NHS remains publicly funded, publicly provided, and providing high quality care to all those who need it. Following our event tonight, a little advert. Our next lecture will be with the Shadow Secretary of State Andy Burnham from the Labour Party on Monday the 30th of March. There are still places available for this event, and so to book your place, please speak with one of our conference unit later this evening, or if you're watching, just have a look at the link next door to this video. So, our speaker, Louise Bourse, MEP, is not only UKIP's health spokesperson, but also the member of the European Parliament for North West England. She has a background in acting and theatre, has performed in both the West End and indeed a number of TV shows, including Peak Practice and Brookside. But her political career started in 2003 when she was first elected to Congleton Town Council, and then she entered the European Parliament as an MEP only recently in May of last year, and almost immediately afterwards was asked to be the party's health spokesperson. Ladies and gentlemen, Louise Bourse.
Thank you, Mark. Good evening, everybody. Thank you so much for inviting me here this evening. You know, this is the kind of thing that I agreed to do. First of all, quite nervous actually, because obviously being the novice amongst all the health spokespeople, but I hopefully with what we've put together, the people that I've worked with, I hope this does them proud, and I really hope so. In fact, somebody's in this room who's helped me a lot. They will remain anonymous, but I hope I do those people proud who've helped me put this together. UKIP believes in the NHS. We and the British people are fully committed to looking after the NHS, and I believe the vast majority of people working within the NHS are fully committed to looking after the British people. But I truly believe that 60 years after its inception, it's the NHS that needs some emergency care and nursing back to health, mainly because it's become a political punchbag, in my opinion. Dysfunctional targets are imposed and dropped depending on what is best for the government of the day. Endless top-down reorganisations that you people here in this room will be all too familiar with take place not because of clinical need but because of political opportunism. Money is pumped into the NHS. NHS management with high executive salaries, repayments of the hastily signed PFI deals, and policies of uncontrolled mass immigration pile on the pressure, and I believe patient care and treatment suffers. The established parties are willfully ignoring the fact that the NHS should not be about politics, but about people. You, basically, the people who work in it, but most importantly, the people who actually use it. And as you know better than most, the British people do care deeply for the NHS. It's an institution that they hold very close to their hearts. And it's because of this, the mainstream political parties use it as some kind of weapon with which they can inflict maximum damage upon their political opponents. Now, when I was asked to put this together, I asked real people about their real experiences within the NHS. And I do mean real people, not Westminster focus groups. I don't class those as real people. And I spoke to hundreds of people. And basically the four principles that I'm going to talk about were their overwhelming experiences. So pregnant women and new mums, they told me that they weren't getting what they needed from their maternity ward. The elderly told me that they were in hospital for too long because there wasn't a care plan in place for them when they got home. Those visiting accident and emergency told me that they were having to wait longer than ever before to be seen. And those who were trying to get GP's appointments told me that it was an absolute battle sometimes at a time when they were least able to fight. So after this initial research with the people, the users, I then went to the clinicians. I set up a policy working group that contained GPs, surgeons, nurses, paramedics, other clinicians, NHS accountants and administration staff. And we met on a regular basis. We shared ideas and policy proposals, and we had a really very argumentative at times, boisterous set of meetings. And what was really important was the group was set up without any hidden political agenda whatsoever. I wanted to know as much as possible about the current situation. So what the public's experience was and what the professionals honestly thought about what could be done to improve the NHS. So the objective for me was not the justification of an already written policy, but it was the policy itself being put together by people who really knew what they were talking about. So I threw some policy ideas into the mix, things that the public had already said they wanted, and the group discussed them, dismantled them, and we reconstructed them into policies that they said they thought could work. But in the main, the policies are the creation of the group, and for that I'm incredibly grateful and very proud of the results. It's a set of policies from people that know about health and the NHS, not from people who know a lot about political spin and electioneering. And I think that was the real difference that I wanted to make. So as a result, the group's work are rooted around 4 key principles. There must be an unwavering focus on patient care and patient outcomes, and that must always come first in any decision-making process. The NHS will remain free at the point of delivery and of need for all British citizens and qualifying foreign nationals. UKIP pledges an additional, fully costed £3 billion more for the NHS every year. We'll insist that that money goes into frontline resources, so that's doctors, nurses, social care, not middle management, not spin doctors, and not non-jobs, what I call non-jobs, of which there is a plethora within the NHS. We are committed to tackling PFI debt, excess bureaucracy, wasteful spending and the abuse of NHS treatment. So let me tell you what I think that's going to mean in practice. First of all, we will spend £3 billion more on the NHS. So in terms of numbers, that is 20,000 new nurses, 3,000 new midwives and 8,000 GPs. We'll invest funds into training GPs and encourage those who have left the profession to come back into work. And UKIP is particularly keen to encourage the 40% of women GPs who leave the surgery before the age of 40 back into the surgery. And we're going to do this by allowing women to take time out from their 5-year free tuition fee qualifying period to have families if they wish, and by not charging either men or women for their own retraining on returning to the profession. To cut GP waiting times, UKIP will also free GPs from the burden of what I think is unnecessary data collection, target chasing, revalidation and appraisal work. I believe that actively prevents people from engaging with patients. And this was the overwhelming and very vocal view of the GPs that I have talked to. Now, a very personal aspect of this policy for me is regarding dementia research and Alzheimer's. As somebody whose grandmother and 4 of my grandmother's siblings all succumbed to Alzheimer's, it was a kind of a really personal challenge for me in how I could kind of put something together which would represent what the Alzheimer's Society UK had told me about. I met with them, in fact I have a meeting with Alzheimer's UK next week, but the Alzheimer's Research UK, they really opened my eyes the time that I spent with them. They obviously told me I couldn't believe, for example, that it's the biggest killer of women over the age of 55. I found that staggering. I mean, that's something obviously as doctors you know, but I found that statistic completely unbelievable. And the 5th biggest killer of men, that's another one that completely, I just couldn't believe. And with an ever-aging population and more people than ever concerned about dementia, it became obvious that this was something that had to be looked at. So I spoke to the researchers and I asked them specifically what they wanted. And so UKIP will ensure researchers receive the resources they require in order to tackle this disease effectively. So we have pledged in our manifesto an extra £130 million per year to dementia funding. We are also going to seek to abolish the annual assessment process for continuing healthcare funding for people who are suffering from degenerative terminal conditions. Because when I spoke again to sufferers and their families, it seemed an absolutely appalling thing to put them under a yearly review in order to keep their funding going. Absolutely inhumane, in my opinion. Secondly, we said we would stop outright wastage and bad management. We lose between 700 million and £2 billion, and they're government figures, they're not UKIP figures, every year through health tourism. That is foreign nationals who come to Britain specifically to get NHS treatment or prescriptions. They don't pay their bills, or people who are living here illegally. So we will cut this bill by insisting that migrants, students and visitors have approved National Health Service medical insurance. Again, another staggering statistic when I was researching this was I could not believe that just 2 hospitals here in London were owed over £8 million by foreign nationals. Just 2 hospitals, £8 million. We've seen of late appalling scandals and cover-ups in some hospitals, inexcusable failures of care that have claimed lives and caused immense heartbreak, and often management failures, not clinical shortcomings, contribute to these scandals. And so UKIP proposes that NHS managers should be subject to the same strict discipline as you, the clinicians. Obviously, doctors subject via the GMC, nurses via the Nursing and Midwifery Council. So we said, why shouldn't management be subject to those same regulations? So under UKIP, NHS managers must have a licence to manage as a statutory requirement. Removal of the licence would ensure that incompetent, bullying, negligent managers would not be moved sideways, as we see all of the time, and they certainly would not be employed by the NHS as external consultants, which I think is one of the biggest crimes of money wastage. When I looked at this and saw how much money they were charging per day. Thirdly, we're going to make sure the NHS works properly. 1 million bed days were lost last year because patients could not be discharged from hospital, even though their immediate medical needs had been met. And they were unable to leave because there was insufficient help for them or care at home, or there was nowhere to send them for long-term care. And I think this is one of the most shameful, failed aspects of our health and social care provision. Social care is woefully inadequate. We're treating people inhumanely, and it's mostly elderly people who need help in their day-to-day lives. I mean, most of these people have worked all their lives and paid into the system for decades. They've helped to build our economy. They have paved the way for us all to enjoy the lives we have today. And yet councils only fund 15-minute visits from carers. And some councils in my area in the northwest of England, even less. We're now down to 8-minute visits in some areas of the region that I represent. And this is a symptom of the disconnect between health and social care. So UKIP will integrate health and social care, bringing both back under the control of the NHS and merge funding back into a social care fund. Merging these funds will reduce bureaucracy and administration costs, whilst ensuring that professionals working within the NHS and the local authority communicate more effectively and in the best interests of patients. There's much we can do to improve the quality of care. UKIP, for example, expects home care agencies to pay the minimum wage to their staff and to pay them on duty or in training. There's no excuse for a big care company to hire anyone on a 0 hours contract, or not to pay them when they are travelling between appointments or on call. What these unscrupulous employers are doing is plain and simply stealing people's wages. They are destroying the culture of good home care by not treating workers properly. So in our new integrated health and social care model, we will not allow the NHS to hire them on that basis. As you know, the NHS is Britain's largest employer. It's the 5th largest employer in the world. It must set an example in everything that it does, and that includes ensuring that paying conditions are fair for employees and contractors. We also intend to deal with the problem of elderly abuse. The Care Quality Commission, the organisation that's supposed to scrutinise care for the elderly and put right any wrongs, isn't working. It just isn't working. And one care home whistleblower told me that the media have actually closed down more abusive care homes than the CQC. So we will scrap the CQC and monitor, and put both under the remit of our locally elected county health boards, who will have the power to do unannounced spot checks across all local NHS and social care services. And those same boards will be tasked with a statutory duty to take evidence from, protect and investigate the allegations of whistleblowers, and support the friends and families of those who suspect their loved ones are not being cared for as they should wish. We have to have the right policies for nursing. Now, the NHS may be the biggest employer in the UK, but it still doesn't have enough nurses. So UKIP want to redress the imbalance of there being too many managers and not enough frontline staff. So we will simplify procedures for clinicians and nurses returning to work within the NHS. Nurse training should take place on the ward and not in a university lecture theatre. There's a desperate need, I believe, and we've seen it in scandals up and down the country, to bring compassion back to the heart of nursing, to negate the too posh to wash attitude that has been highlighted in many of the scandals we've recently seen. You know, patients should never again die on a ward because their basic need to be fed, given something to drink, or be kept warm and comfortable are not met. To that end, UKIP will bring back the state-enrolled nurse. Training will take place on the ward, utilising the current pool of auxiliary staff and allowing them to work towards the state-registered nurse qualification. Our nurse managers will be responsible for ward cleanliness, the efficient operations of the ward, and oversight of nurse training on their ward. And UKIP will insist that any foreign health professionals working within the NHS or social care system must hold appropriate qualifications to speak and write English to a level that is acceptable to the profession. So this is what UKIP will do to protect the NHS that I think the people care so much about. We will give the NHS the money I think it needs. We will put an end to waste and bad management. We will integrate health and social care so that patients are cared for by the right people in the right place. And we'll implement a whole range of practical policies to improve the quality of care, especially, as I have said, for the elderly, and that is really important to me. Our set of NHS policies are based on the experiences, needs and desires of real people, people who work and live outside of the Westminster bubble, the people for whom the NHS is absolutely vital. So we're offering the country in our manifesto and an NHS that the public have told me that they want, an NHS that they say they need, and an NHS they say they are happy to contribute some of their, to work towards contributing in their day-to-day lives. It has to be fair, it has to be fully functioning. And I think UKIP's health policy, what we have put together, shows beyond doubt that we believe in the NHS. It's a policy formulated through the experiences of real people and, more importantly, real clinicians, because at the end of the day, it's those people, the clinicians, the people who are at the coalface of the NHS, who are the NHS. And if this does anything in our way, if we can put anything out there, it's the fact that I think too often we coined a phrase in my group, GP bashing. And it seemed to me that that happened rather a lot over winter with the A&E crisis. And I think what we wanted to put together was something that actually showed people who work for the NHS that what the job they did was amazing. They were dedicated people, and the majority of those people were dedicated to nurturing and caring for the people who walk through their doors. And I think a lot of people feel maybe not cherished, and I think that's really important that some of the people who work at the coalface feel that once again, and that, if anything, is one thing that I would like to get over in this policy. So thank you. They're just a few highlights, and like I say, I'm sure Mark and we'll take questions now. Shall I come and sit back down?
Right, so now we're open to the floor for any questions anybody wants to ask. And first person I saw was Aaron. Don't forget to wait for the microphone and then introduce yourself.
Aaron Barbara, surgical trainee from Mersey region. Thank you for that talk. I was reading the UKIP health policy today, and a couple of areas that I'd like to have a bit more detail about. First of all, naturally you want to leave the EU, and you are committed from your policy to reviewing the working time regulations. And I think this is something that might be quite a concern to a lot in the profession who believe that those regulations are an essential and hard-fought safeguard against unsafe working hours and consequent patient danger. Another point is you mentioned the CQC being replaced by independent local boards, which seems similar to the police and crime commissioners in criminal justice, that a lot of people have questioned whether they work or not. And finally, this figure of £2 billion from health tourism, I did some reading on that.
Aaron, I tell you what, how about we come back to those?
Okay.
It's not fair to blizzard somebody with so many questions. Let's take the first two.
You have to remember what the first one was now.
That was about the working time directive.
Working time directive, of course.
And the risk to patients of unsafe working hours.
Yeah, well, from, like I say, the clinicians who I've been working with, the thing that what they wanted to see was a separation between education and training. And at the moment, I believe it's all they class the training, don't they, in with the 48 hours.
That's correct. I think that's the nature of our training. We train at work.
What they wanted, that they said basically impedes them, and what they would like to see is a separation between that. So because they felt, especially people who were specialising, that they didn't get the training that they required in order to go whether they're going to whatever their speciality will be. And so the feeling was, certainly with the group that I've worked with, that they would like to see a separation. Now, I granted, I absolutely agree. We don't want doctors working hundreds of hours and unsafe. That's absolutely crazy. But obviously, all I can say is the groups that I've had and I've worked with, they felt that it impeded education and training, and they would like to see some kind of clarity so that the two could be separated and not included in the 48 hours.
And how would the extra hours be funded?
Well, why would they be extra hours?
Because we're currently a contractual maximum 48 hours a week from EWTD. So if we're having to work more hours, presumably we should be paid for them.
Presumably, though, you'd be doing that, wouldn't you, if you were training for something? I mean, like, I hold my hat. I am a complete novice. I'm not a doctor. I'm going by what I am told by my policy group. It isn't. If you're training towards something, don't you do that anyway?
No, I think service and training are very much linked, and I think it's quite difficult to try to pick the two apart like that. But I'm more than willing to talk to you about that afterwards.
Well, like I say, I mean, I can bring that up with my group and talk and talk to that. Maybe these are ideas what we have thrown about. And obviously, though, for the fundamental point, yes, we do want to withdraw from the European Union. We do not believe that any directive is a good directive, and we should be. It's our government who should set those targets, not Brussels. That's the fundamental point.
Okay, and I think
can we take Darsha, and then we'll come back to you if that's all right.
I don't quite know how to follow that. Darshan Brahmat, I'm a cardiology registrar in Norwich. I'm really glad you came to speak to us. There's lots of new policies I'd not known about that I'm now better informed about. One of the things I found a little bit surprising was your view that we should roll back on targets, stop the data collection because that's a waste of time, or you intimated that took up time that could be used elsewhere. I'll speak from my own field of interest, which is defibrillators in heart attack patients. So at the moment we have, I think, the third or fourth lowest rate of putting in these shock boxes which stop people from sudden cardiac death in Western Europe. So our target as a country is 100 per million as a minimum. We're nowhere near that. I think we're somewhere at 72 per million population. Western Europe averages somewhere around 150 per million. And if you're in the Czech Republic or Germany, you're well above 200. They've managed to get their rates of implant for these patients who will benefit, who will live longer and live better, to have these quite expensive treatments. If we don't collect the data and we don't measure ourselves up against other people, how will we know that we're giving our patients the best possible care? Because I understand about targets being cumbersome.
Absolutely.
How do we get that balance?
Well, obviously, some data is. I had it described to me that in terms of disease control and things like that, that kind of thing. There's always going to be some things that we're obviously going to need to record. That goes without saying. Again, I'm speaking as a non-clinician. I'm speaking as an NHS user. However, the one thing that I have had more letters about than anything from GPs, for example, is the fact that on average they could see patients that they are tied up with what they see as unnecessary and burdensome data collection, appraisal work, etc. And they feel that stops them from actively seeing patients. And I think if we can free GPs from that burden, there's always going to have to be something, like you say, that that will be useful. But again, overwhelming, I cannot tell you how many emails I've had and comments I've read underneath press releases and emails, etc. And overwhelmingly, I have to say, the response has been from GPs, yay, please do 3 years, because we are literally constricted by this ridiculous amount of tick box culture. I'm sorry, it came in with the Labour government. They were obsessed by it. And it's not stopped. And although granted, I'm sure there are many useful bits of data you can use in research, etc. But again, from all the people, and I'm speaking about hundreds upon hundreds of pieces of information and emails and interviews that I've had with GPs, absolutely the overwhelming attitude was that there is too much and it actively stops us from engaging with patients. So I can only really tell you what I found as I've been working to formulate this policy. So that is what I found.
No, we'll go to Lucy next, then I promised we'd go back to Aaron.
Okay.
Aaron, sorry.
Hi there. Thank you so much for coming to talk to
Hello,
us.
hi.
Hello, my name is Lucy Jane Davis, and I'm a public health doctor based down in Bristol. So you won't be surprised to know that I think data collection is actually incredibly important, because obviously planning for a population going forwards is incredibly important and it shouldn't be underestimated. And I have to tell you, my husband's a GP and also agrees with me. Okay. So some of the burden is about how we organise services rather than necessarily actually about collecting information. But my real question was actually about smoking. Yeah. You might be aware that the BMA has policy that we believe that nobody born after the year 2000 should ever be able to buy cigarettes. Do you think that's something that UKIP would ever subscribe to? And if not, what do you think UKIP might do about smoking?
As a mum, obviously I absolutely agree. As a mum. It's a really, prevention, the one thing I've learned sort of pulling this all together is about prevention. How we have to look at how things are prevented. So obviously things, smoking, alcohol, and obviously obesity are the big, how do we prevent those things? Smoking particularly, do I think, for example, that plain packaging on cigarettes works? That kind of, those kind of initiatives? Probably not, actually. I think it probably makes the counterfeiter's job far easier, I would imagine. How do we prevent, education at home? Yes, of course we want to prevent young people from smoking. How we do that? But I do not believe, I come from a different place where, I do not believe in a nanny state. I think people should be free to make their own choices. We all have, we're all adults. If we choose to smoke, if we choose to drink, if we choose to eat fatty food, then it's our body. We should be allowed to do with it what we want. Now, whether, yes, protect your children. I protect my children. And I would hate to think that a child can walk into a shop and buy cigarettes, but then again, we already have laws in place so that they can't do that. So, do I believe in any more stringent measures?
Can I just press you on that point? The evidence from Australia is that plain packaging does work and doesn't increase counterfeiting. There's been quite a lot of publications in the British Medical Journal about this, although I appreciate opinions can differ about whether that translates from Australia to here. But you talked about protecting children. The vast majority of smokers in this country were child addicts, dragged in by an industry. Are you not impressed by that? Do you not want to stop that?
Well, I think times have changed. I think those people, kind of like my dad's generation, who smoked from when he was like 12, 13, I think it was very different then. I think the world has changed, society has changed. I don't think there's no advertising now, that's gone. The packages now contain horrific images of when you actually see a cigarette package, and that's enough to put me off. I wouldn't want one. But I believe people have free choice. And if people are going to go and do that, they're going to go and do it, I'm afraid. Well, how we look at prevention, I think alcohol is a bigger problem. I think that we should look at alcohol more.
Mr. Barbara, and then that gentleman there, I'm sorry, I don't know your name.
I just want to ask a little bit more about that £2 billion figure.
Oh, yeah. Sorry, yes.
That's all right. No, that you put on health. I appreciate I asked a number of questions on the cost of health tourism. I don't pretend to be an expert, but I've done some research, and it seems to me that £2 billion is the total cost of treating foreign nationals in the UK. but that includes foreign nationals being quite properly treated because of bilateral and EU-wide reciprocal agreements for healthcare. So what would happen then if you stopped treating them? Would you anticipate that the benefits for British people overseas are abolished
You talk
at
about
the same time?
the E111 card and things like
Yes.
that. Yeah. No, I don't. I mean, that, like I say, those reports, if you go into those reports, there's anywhere, and like I said in the thing, between 700 million and 2 billion.
Yeah.
So it's a wide-ranging figure. The only
Right.
bit of that money that I actually need is 200 million to abolish hospital car parking charges across England. So as long as it covers that, I'm happy with that.
So the rest of the rest of the £3 billion is coming from other savings.
Yes, absolutely. Yes, it certainly doesn't come from health tourism, I can tell you. What was the second part of the question?
No, that was about it. About whether you would anticipate the reciprocal agreements that we enjoy being abolished.
No, and the people that I've spoken to, again in my groups, it's very arbitrary that the E111. I mean, you can take that card into some countries. Some people have had very good experiences. Some people have had very, very bad experiences at receiving reciprocal treatment. So I don't think that works. I don't think that works across the board as it should. Anyway. And I think as British people, we as a matter of course tend to purchase medical insurance without even thinking about it in our holiday insurance. I don't think it's a big thing to ask people to do. I think it would be a really, really positive measure. And I don't think people would bat an eyelid, to be honest.
So if we withdraw from Europe, there won't be a European health insurance card?
Well, no, but I mean, we buy insurance. For British people, generally, we do not bat an eyelid when we go abroad. We buy travel insurance. We don't even think about it. It's like a matter of course. And I don't think people would have any trouble coming back the other way. Okay. I just think it's something people wouldn't bother about.
Thank you. Gentleman in the blue jumper.
So Chris Morton, GP from Gloucestershire. 2 points. The first thing, any thoughts UKIP about how to incentivise people to improve their own health care and responsibility? I speak as a taxpayer. If people wish to smoke or drink, that's fine, but I don't really want to have to pay for the down costs on that. They can do it if they want to. The second thing, really, a different thing, social care at the moment is means tested, healthcare is not.
Yeah.
Any plans to alter that strategy?
The incentive, yeah. I mean, I think at some point we have to have kind of like a carrot and stick approach to incentivising people into looking after themselves. I mean, we were talking before, smoking, drinking, obesity. From talking to my group and working with my groups, they're a massive burden, those three kind of sectors. So how do we do that? I think one of the things that might be interesting is if the NHS looked at, instead of spending so much money, I did have it written down actually, because I thought it was really interesting. Anyway, I've obviously forgotten that bit. The NHS spends more on surgery, gastric bands, bariatric surgery, than it does on lifestyle maybe courses or something like that. So maybe we could look, instead of spending money in that area, maybe we should redirect that money into helping people to make better choices. Maybe that would be an interesting option to look at. And then I tell you, I'm not against things like fines. Again, it's not something that's in the policy. It's not something we can't include everything. But personally, I think an interesting thing for debate in the future would be fining people maybe alcohol, drug-related admissions to hospital. Those kind of frequent flyers that the paramedics talk about a lot. I've spent a lot of time on paramedics, with the paramedics, and the people who they call frequent flyers. Maybe some kind of fine system. So people start to take responsibility for the NHS, for their abuses of the NHS. I think they're kind of things that maybe that's a debate to have in the future. All these kind of things have been brought up. So I think that would be a carrot and stick approach. You thought you were going to get a fine if you were kind of one of these people who were, they were picking up every week off the street. Maybe that's something like that. But certainly, I think obesity, alcohol, smoking, they're the three areas, aren't they, really? How we do that. But like I say, as a party, I'm very against, as I've said before, the smoking, the nanny state, people make their own choices. We're all adults. You know, how we abuse the NHS is another thing altogether, and that's I think that's the part that we should need to look at, whether we look at fining people and things like that. But like I say, that's a debate for the future, and whoever takes over in May.
Can I press you about spending commitments?
Yeah.
You mentioned £3 billion a year extra.
Yeah.
You're probably aware that the Nuffield Trust and other observers, such
Yeah.
as the NHS Confederation, have calculated that a funding gap of about £30 billion a year will open up over the course of the next Parliament. Is the £3 billion a year cumulative? Does that start to address the gap? Or is that £3 billion a year in the first year and then maintained afterwards?
Yes. Basically.
So it'd be three and then six and then nine.
So basically, the $3 billion, obviously, the first 2 years, so obviously, we UKIP, we obviously, as you rightly said, want to withdraw from the European Union. That $3 billion figure comes from, is in the third year. We would get that money from obviously redressing the balance in terms of membership payments to the European Union. In year 1 and 2, obviously we have other, you know, we obviously want to dramatically slash the foreign aid budget and things like that. So we want to get, you know, so we feel the money is there, and a lot of that money is directed in the wrong places. And it's all about, you know, and that's without looking at cutting anything. You know, the money is there, it's been directed in the wrong way. We would like to see that redirected.
So, just to be straight, by the end of the Parliament, the NHS
So
budget would be $3 billion above what it is at present.
Yeah, $3 billion a year.
Okay. So that
every year.
So that leaves $27 billion
It does.
unaccounted
and we've got
for.
Well, they were talking about $8 billion a year. Well, we have to, you know, that's where we're starting from, and we think it's a good starting point, and it's certainly more than and that's without cutting anything. That's without looking at cutting anything. That's extra. So obviously, you know, I think that's a positive place to start.
Okay. You mentioned that healthcare workers should have fair terms and conditions in their jobs.
Yeah.
One of the things that we've all experienced here is 5 years worth of real terms cuts in our pay. The reason being, of course, that in various ways none of us have had inflationary pay rises over that time. I suppose I should put this together with the previous one. Do we deserve cost of living pay rises? And if so, how on earth can you fill that $27 billion a year gap? Because it's the cost of living pay rises the government is actually using to fill that gap at present.
The answer to the first part of the question, goodness, yes, absolutely. I think. Well, I mean, we looked at care workers first because they're the people who are really on the, you know, they're not even paid, some of these care workers, the minimum wage. You know, I mean, they're really not. They're on the 0 hours contract, not being paid the minimum wage. I mean, it's just their entire working day and their conditions are appalling. You know, so we've started from the people who we feel are the hardest pressed, and from, you know, care workers are where we're starting from. And then, you know, we have to look at nurses. I mean, to think that managers have had, you know, when you see sort of executive salaries, executive redundancy payments that go into millions for NHS managers, I mean, that's just, how is that right? How is that right? Why hasn't somebody tackled that or said something about that? You know, I hold my hands up in front of you. Look, I'm a novice. I have no medical experience, no medical training. I am a user of the NHS and a politician. I have been given this to put something together for the election, to formulate a policy. And I formulated that with people who are clinicians and who have real life experiences of the NHS. And I've listened to them and I suppose brought my own experiences into that as well. Care workers first, you know, I think some of their conditions and the things that they have to put up with are utterly appalling. Auxiliary staff, nurses, you know, how has that all been allowed to happen whilst we have literally hundreds of millions of pounds in exec management redundancies? Who has allowed that to happen? You know, that's what we have not yet, I can't understand that, and any of the doctors I've talked to have not been able to give me an answer. I don't understand that. I don't understand how we have a government and the previous government who have allowed that to happen.
Of course, it would be fair to say that the government currently has legislation before the House that they expect to pass, which will allow them to recoup and all those payments.
And let's hope that happens.
And would also allow them to recoup all payments made to whistleblowers in severance and a whole variety of other things as well.
And let's hope that happens. But also, I think we have to look at how the NHS is structured. I mean, it's massively top-heavy.
Yeah.
And I talked about before this plethora of non-jobs. I mean, it's just. Why does a hospital need an art curator?
It makes the patients happy.
Well,
I tell you what, I'm going to go to Darshan.
I have to disagree. If I was, I want somebody to make me better. I'm not interested in looking at a swan on the wall. An art curator. I'm sorry. I mean, it's just madness. It's absolute madness.
Darshan.
Some of the things you say strike a chord. And like you said, the point of an art curator or looking at a swan on the wall, and many of the things you described today sound entirely reasonable propositions. My concern is that when we've pushed you further, your response has been, I'm not a doctor, I'm not medically trained. You don't need to be medically trained to be doing the governance of how the health portfolio would work or how the UKIP party would put health in its plans. And the clear lack of reliance on evidence worries me greatly from the things you said so far. So the idea that you get lots of emails from people saying, I hate paperwork, means that we should scrap paperwork, or I don't see
hang on. I think it's slightly unfair. Hang on a second. That is slightly unfair. I am saying that, I have held my hands up from the very beginning when I took on this role to say I have no clinical experience. And so the people that I have relied upon and I've looked to and the people that I've listened to have been people like you. So if research isn't collating data and collating responses from people, then what is it?
But I thought we weren't collecting data.
But that I'm on about in formulating my policy. If that isn't collect, what is it? That's what you do surely when you're collecting data and for your different research subjects. That's kind of what I've been doing, isn't it? So you wouldn't discount it. If you had hundreds of responses that were in a particular, you wouldn't discount that. So why should I discount the overwhelming view of the people who I've spoken to?
So I'm hearing that a UKIP party supporting a government or as part of government would be very keen on populist voices in determining its policies.
I love that word, populist. Do you know what I mean? Something's popular for a reason. It's because lots of people agree with it. So, I don't see that as kind of I don't see something. If something's popular, lots of people agree with it. That's it. So, if lots of people have told me one thing, I don't understand why that's a bad thing. Why you discount that?
So the biggest populist idea at the moment in my areas of practice would be alcohol pricing. And you said before, alcohol is problematic. Frequent flyers. The scenarios you've described. I've not come across anyone who's a frequent user of alcohol, whether drinking it, smoking it, or whatever with it, who said that minimum pricing is a good idea. And in fact, as a populist idea, most people I know who drink alcohol would say that actually we should drop the price, and that would be the best way forward. That's not best for public health, that's not best for reducing alcohol-related crime or alcohol dependency or alcohol-related health problems. But as a responsible government, we would expect...
Absolutely.
So where does the balance lie?
Well, I think something like minimum pricing for alcohol is an excellent idea. We've been very, I've spoken about that before. I think minimum, the fact that a unit of alcohol is worth less than, you pay more for water than you do for a unit of alcohol is completely bizarre. So, absolutely, they're the kind of things that I would think I would like our MPs to support. I think that would be a really positive thing.
Aaron.
Sorry, yes, me again. Just want to come back to GP services, which might be ironic from a surgeon. You mentioned that recruiting 8,000 extra GPs. Again, I'm wondering where these GPs will come from, given there's a massive undersubscription for general practice in the current system.
Okay, well, we are hoping that we're linked in with our education policy, where we have no tuition fees for people who are taking STEM subjects. So we are hoping that the fact that those courses at university would obviously mean that more people want to take those courses, because that's why we've got a skills shortage.
I'm sorry, could you say what STEM subjects are?
So like sciences, medicine, you know, those subjects. So our education, again, this is just linking with other policy, our education policy, there is no fees for people taking those subjects.
Yeah, I saw that.
So we hope that that is going to incentivise people to take those subjects, because that's why we have a skills shortage. And then also, you know, trying to get GPs back. Why do we lose so many? So example, again, linking in with the education, we have if you qualify as a doctor, and you stay in this country working as a doctor for 5 years, paying tax and national insurance, you will have no student loan to pay back.
Right. Now that's quite interesting, but I mean, obviously the lag time on a GP is 10 years coming through from medical school to being a qualified GP, so that's a long time. Does that mean you're committed to increasing medical student numbers? If so, by how many? And again, how is it funded?
That's the education policy. I can just tell you that linked in with the health policy, there is, on those STEM subjects, there is no tuition fee courses. And also, if you stay in this country working and paying tax, there'll be no payment of your student loan back. You would have to pay that if you then went before the 5-year period was over. I talked about that, you know, trying to get people back into the surgery. That 5-year period, for example, if a woman wanted to go away and start a family, that 5-year period wouldn't be affected with that.
Gentleman with the pocket square.
Hi, my name's Arash. I'm a final year medical student. You've painted a really good picture about what a UKIP health policy, if you had a full say, would look like. If we come to mid-May and you're part of a coalition negotiation, what, if any, of the policies that you've put out today would be absolute red lines for you?
Oh, that's a really good question. I'll tell you the two things that I feel really strongly about, the two things are the SENs and the dementia funding.
So would they be red lines if they were as part of any coalition negotiation?
Basically, yeah. I mean, after May, obviously, this, you know, I've done my, you know, hopefully leading up to May, I've worked with the groups, I've pulled this together, hopefully it'll be coherent, and when we release the full, what you've read at Jan before was actually just a statement of principles, because we haven't actually released the full policy yet. There's other things in it. We're not releasing that until we release the manifesto. But for me, for whoever takes this on as an MP, because I do believe it has to be an MP who takes this on, it shouldn't be an MEP because it's a domestic policy, the two things that I would hope they would absolutely fight tooth and nail for are the return to SENs and the dementia funding. They, for me, would be non-negotiable.
And that seems an appropriate moment to call in the gentleman at the back.
Can't see the
Ravindra
hello.
Jaiswal, psychogeriatrician. With regard to dementia funding,
Yeah.
you're going to put money on research, a bit late, but better late than never. What about those patients who suffer from dementia and go for a long-term care in a residential or a nursing home, and they have a lot of money, wealth? Have they to pay for their own wealth, or the government or you will pay for it?
Well, what we want to see, like I said, is health and social care merging into a social care fund. And I know that social care is obviously means tested. Now, obviously, the detail of that is something that you know, would have to be argued later. If somebody obviously had pots of money in the bank and somebody had absolutely nothing, I think it does have to be means tested in some respects. I think that's only fair and equitable.
Well, this is a guy who has never been on holidays, saved the money to pass it on to the children. And there's another one who's going to Costa del Sol, XYZ, spend all their money, haven't got any money. So I have seen tears rolling down the children.
Because they're upset. I understand, yeah. I can see what you mean.
It's not fair for them.
Somebody who's looked after the money and been careful and prudent.
Yeah.
I completely agree. You know, that does seem not fair.
So it's something, obviously, you need to look at it, because time after time, election after election, politicians promise all sorts of things, and it never happens. 20 years have passed. These dementia research, it was in the late 90s when all these drugs for dementia came into the market, which was prescribed in America, and patients were getting those from their relatives from there for prescription here. And when those were available here, because of the cost implications, the fashion of the day dictated whether or not these drugs be prescribed or not. And when these drugs lost patency, then there was a hurry that dementia has been underdiagnosed and pressure on doctors to diagnose more dementia. So all these sorts of things are happening, but because you're so much involved in dementia, I thought it would be a good idea to mention it to you.
I think that's really interesting. I mean, the 130 million, I mean, I didn't pluck that out of thin air. That came from, that's what Alzheimer's Research UK say they need every year. That was the actual figure, which is where that's come from.
And second question, which is completely different.
Oh, okay.
Will the UK Independent Party keep bodies like the DDRB independent, or they would like to sort of encroach on their powers? DDRB is a doctors and dentists review body who looks into their pay and things like that.
I think
it's a pay review body that makes recommendations for doctors and dentists.
All right, okay. I think I would presume those things have to be independent, don't they? That's a good thing. I would say that's a good thing.
Okay, thank you.
Yeah.
Can I ask you about something that's much in the news at the moment?
Yeah.
7-day services.
Yeah.
Does UKIP think 7-day services are a good idea and should be implemented? Have you any thoughts about them? And in particular, can it be done, as the present government says, on a cost-neutral basis?
Gracious. I can't see how they can be. 7-day services, in an ideal world, wouldn't that be great? Especially if you were working, working 5 days a week, working mum, working dad, that kind of thing. So a perfect world, we'd love a 7-day service, and we'd also like evening surgeries as well. That would be really great. What we have said is that we would, we all have to hold, there is a difficulty. It is hard in some areas of this country to get a GP's appointment. Nigh on impossible. Funny, I rang this morning to get a GP's appointment for my own doctor, and the earliest one he could offer me was April 22nd. So I laughed. But, so there is a problem somewhere. Something's going wrong, And again, that's the overwhelming... So what we have said is we would like GPs to accommodate working people, so that there is, if you work 9 till 5, you can't go to a surgery, and an evening surgery would be good. And also maybe 1 day at weekends would also be something to look at. But if we give doctors, if we free doctors from what I can see, I know we've obviously talked a lot about the data collection, the revalidation, the appraisal work and all the kind of paperwork. If we free people up from some of that, well, surely that's going to mean they have more time to offer more appointments, and that's a good thing. So are we going to redress that balance like that by freeing them up? I think 7 days a week is an impossibility. What if you were to see a doctor, a GP working on your own in a small kind of country surgery or in a village? How could you offer a 7-day service then?
Or what if you're a single parent junior doctor with children?
Exactly. You can't expect that from people. You can't. There's got to be a balance. How they achieve that balance. I think probably is going to be looking at some of the way we tie our GPs' hands with paperwork. I think that, there was a fantastic article in the Times by a doctor who it was absolutely great. And after I'd read it, I got in touch with him about how he felt that he could be, 1 day a week, he felt if you added up all the hours that he was stuck doing all this kind of paperwork, he could have 1 day a week more to see patients. So there's something going wrong. I absolutely respect that you say, and what the lady said here about her, that yes, obviously we need something, but something is going horribly wrong if we're tying people up to that extent, and actually actively stopping them from seeing patients because they're, there was, where I'm from in the northwest, again, and I have seen a letter saying that under the test that we have now, the tick box, the validation test that we have now, Harold Shipman would have come out as a really good GP on paper. That's absolutely true. Harold Shipman, he would have been up there at the top of the list. I'm afraid there's so much more, isn't there, to medicine than filling in boxes and ticking. What about actually engaging with people? Why can't we go back to having people registered to a doctor instead of a practice? So they have a doctor who they grow up with and they form a relationship with and they trust That's gone now because all we have is a huge, great big medical practice, and we never know who you're going to get. I mean, I think that's sad that we don't have a doctor now that we grow up with. I think that's a really sad thing.
Of course, if Dr. Shipman's tick boxes had included the number of his patients dying, you might well have been picked up earlier. But of course, we're taking away revalidation, the CQC, monitor, all of the regulators.
We are, but we're replacing them with our county health boards, and the county health boards, just before you go, the county health boards are going to be made, they're not going to be anything like the police and crime commissioners, if that's what you're going to say, because I think they're a complete waste of time, and we would fight to have those scrapped. The county health boards are going to have a locally elected chairman who is going to be the accountable person, that public figurehead. But the board, very importantly, is going to be made up of clinicians, of working professionals in that area, and not just doctors, GPs, people from primary and secondary care, but community, third sector, voluntary groups, social workers. We want those people, so that all those people working together in a more integrated approach, because I think primary, secondary, health and social, we need to integrate that with one figurehead who can be ultimately held accountable, is the way to go. Bring it back for the for the people.
And we are almost out of time. The last
okay,
one is,
sorry,
of course, the irrepressible Aaron Babora.
It was just coming back on exactly how it would... Sorry. Yeah, it was just coming back on how they would differ from the police and crime commissioners, because what you've described almost sounds a bit like an old-fashioned regional police authority and that kind of thing, and that this is the only area of the public sector I'm aware of where we've had these things.
Not politicians.
Right.
And the reason that Manchester, what they've done at the moment with the money in Manchester, devolving the money in Manchester, on the surface, everyone, that's great, we can spend. It's horribly wrong. It's the ultimate privatisation of the NHS, because you are giving that money to councillors and to people who are political animals. That is completely wrong. The people who know what the community wants, know what the people want, are clinicians, they're doctors, the nurses, the social workers, the GPs. They should have the power, not a bunch of politicos sitting in a city hall or a council chamber. Feel very strongly about that. I think that is the wrong way to go. We should be talking to people who know the communities and know what the health needs are of their communities. That is really important. And really important.
No, I think I think there's a lot of mileage in that. So just very, very okay.
Thank you. I'm going to claim...
Oh, you're very excited.
I'm going to claim the privilege of asking the very last question. I know a little earlier you saw our No More Games tower outside.
I did, yes. I naughtily called it by name, didn't I?
You did, didn't you? So we've recently launched a new campaign calling on politicians to stop playing political games with the NHS. Yes. We want to talk about parties taking a long-term commitment. And I want to ask you what UKIP can do to ensure that the debate on the NHS moves beyond political point scoring.
Well, goodness me, that would be fantastic. Whenever you try and raise any kind of debate that is outside of the normal parameter. I was having a conversation actually before we sat down. You can't say anything about anything like that, because as soon as a politician, because as soon as you do, you have all the media jump on you, and it's all publicised, scaremongering, they throw it out there, loads of misinformation. One thing we have to do, and I think the only way we can move forward, is by politicians being honest and saying we have to look about how this organisation is funded, about how it's run, about this very unwieldy, top-heavy management structure that's there, and we have to look of changing it. Be very open and honest and say it can't possibly be sustainable. It can't be sustainable, so what are we going to do about it? But you know what, until we've got a group of people in Westminster sitting on that green leather who actually can talk about that without then, trying to knock each other down, privatise the other, it's never going to happen. It'll never happen. That's my answer. I don't think it will ever happen, because they're all too bothered. It's very easy for us because we're the smaller party. We were saying this before. We're the new kids on the block. We're only a couple of decades old in terms of political. We're embryonic in terms of political parties. So it's a bit easier for us to kind of have that knockabout and be a little bit more honest, I think. But if you're looking at that from the Labour and the Conservatives, they will never be honest. They will never be honest, because they can't be. And they know that if anybody does say anything, looking at different models, again, I was saying, when I go back to Brussels, I'm an MEP, not an MP. When I hand this on to one of our MPs in Westminster, the one thing I'm very interested in looking at is different European health models, and that's what I'll be doing in Brussels, to see if there's something we can learn from different European countries and how they work, and if we can have an honest debate about that. But I think if you're expecting an honest debate from the big two parties, I don't think that'll ever happen, because they all realise that it's now so weaponised, to use their own terminology, that there'll never be an honest debate, and that it's just all about political point scoring. And I think the time for honesty with the big two, that's gone.
So we've learned many things tonight. We've learned about Darshan's ability to smoke alcohol. But perhaps moving beyond that, we've heard from Louise about the £3 billion a year injection that she's going to give to the NHS, or UKIP will give to the NHS. We've heard about Louise's own personally inspired focus on dementia as part of UKIP's health interests. We've heard about licences to manage, about paying conditions needing to be fair, and of course this is a UKIP event. We've heard also about the need to withdraw from the European Union and slash the foreign aid budget, both of which will liberate money to pay for some of the things inside the health service. But I think most of all we've also heard about Louise's unwavering focus, as she put it, the unwavering focus on patient care and outcomes that she wants to personally bring to this debate. Ladies and gentlemen, Louise Borse, thank you very much.
Honestly, thank you. Thank you so much for inviting me.
It's a pleasure.
Thank you, everyone. Thanks.